Good morning, everyone. Welcome to TeleShadowing. My name is Amna and I'm a high school student. We are recording this session and live streaming it to YouTube. Today's session will be hosted by Dr. Cheema for internal medicine.
We'll be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they'll be addressed. Dr. Cheema, as you already know, is an accomplished internist. She completed her internal medicine residency from the University of South Florida. She is a mentor to students and a published author in neuroendocrine tumors and a published author in infectious diseases. Dr. Cheema also participates in community services and believes in health for all. She's also running a clinic for low-resource patients overseas.
Hello, everyone. Thank you for the introduction, Minahil. I am humble and grateful. I already shared my brief life story in previous sessions, as we have new students joining us every week. So I'm going to share a brief story, and then we'll talk about internal medicine path, why I do what I do. So let me see, okay. All right, I grew up in the Twin Cities, Rawalpindi, Islamabad in Pakistan. So if you fly in, this is what it looks like. And it's an aerial view. It's very crowded now, but it has a fun life there. And I spend a lot of fun time enjoying the northern areas close to these twin cities, the breathtaking views of nature, hiking tracks, outdoor activities like boating and hiking were my hobbies. I went to undergrad at postgraduate college and did my pre-med there. Then I attended Rawalpindi Medical University in Rawalpindi, Pakistan. And it's a 5-year program over there. After graduation, I did my house job in Holy Family Hospital and Rawalpindi General Hospital. That's equivalent to an internship over here. I did house job in internal medicine and pediatrics. I moved to North America and I started preparing for USMLE alongside clinical rotations to learn the health system and to polish my clinical skills. And I started clinical research to contribute in the field of research. And I have a few publications in neuroendocrine tumors and infectious diseases, and still contributing in clinical research projects. I completed my internal medicine residency at University of South Florida in Tampa. Internal medicine is a 3-year program, and I had a great time of my life in Florida, along with my kids, and who enjoyed the Disney World there. Every other weekend, it was 45-minute drive from Tampa, and every other weekend they were at Disney World. So after completing my residency, I started practicing as an internist in both inpatient and outpatient care in Maryland. I'm a mother of 3 kids. And my youngest one is doing her part of awareness during this pandemic. And I would like to share one of her video for fun. I shared one last time regarding pandemic. Now today is about vaccine. Let's see what she say. Let's see.
Hi everyone, my name is Nora and I'm 5 years old. Welcome to Nora's Healthcare. Today we're going to talk about the importance of vaccine. We are in April 2021 and still facing the coronavirus pandemic. At this time, we have 2 types of the coronavirus vaccine. We have Pfizer and Moderna. Pfizer has 2 doses 3 weeks apart. Moderna has 2 doses 4 weeks apart. It's important to get the vaccine to protect ourselves and others. I didn't get the vaccine yet, but my family did. I didn't get the vaccine because I'm not 16 yet. Please get the vaccine. I'm going to give the vaccine to my patient. All done. Most importantly, we need to keep our mask on. I hope we will be out of the pandemic soon. Stay safe and healthy. See you next time.
All right, so I hope it. All right, before taking a ride of internal medicine, let's talk about self-care. As I discussed in my previous sessions as well, and as I mentioned, we have new students joined us. So let's go over briefly before we take a real ride of internal medicine. What is self? What is well-being? And why we need a self-care? So you need to be compassionate with yourself to avoid the burnout and achieve your goals. In medicine, there are 4 years of undergrad, 4 years of medical school, then 3 years of internal medicine residency. And if you plan to 2 to 3 years of different fellowship programs, if you want to pursue that path. So what is self? So self has 4 domains: physical well-being, emotional well-being, spiritual well-being, and intellectual well-being. To talk briefly, all these 4 pretty briefly. So let's start with the physical well-being. So physical well-being has 4 parts as well. Physical activity, make a habit of regular exercise, make a moderate physical activity. It's very vital to keep your immune system healthy. So you can do activities like bike riding, yoga, go for a walk, standing rather than sitting, taking the stairs up and down, stretching exercises on regular basis. So anything that keeps you moving, any movement is better than no movement. And while you're studying, you can, in between every 45 to 50 minutes, have some stretching exercises to help release your muscle tension, and you will feel good. And most importantly, the nutrition. So add nutritious diet, and whatever you eat makes all the different, because nutrition makes all the difference in our immune system. And add wide range of fiber, add antioxidant-rich diet, and choose different fruits, vegetables, whole grains, nuts, seeds, and also stay well hydrated with water. And I can share the daily goals for males is 3.7 liters, and for females is 2.7 liters. So please make a habit of healthy diet. And next, we have you should have a quality sleep. A regular bedtime and wake up time is very important. Aim to sleep 9 hours is optimal, and develop a habit. Set up an alarm, avoid screen time at least 60 minutes before you go to bed. Practice your rituals, like writing a journal, and you can write down your goals for the next day, and read a good book, whatever makes you feel good. And always mind your stress. Listen to your body. Be compassionate. The stress hormone called the cortisol, it suppresses our immune system. So when our immune system is suppressed, we are more prone towards the infections. So please be mindful and adapt some coping mechanism that can help you to manage the stress on a daily basis. And please keep reminding yourself to take care of your physical health, as healthy body has healthy mind. Okay, so next domain is of self-care is emotional health. And we call it emotional well-being or emotional intelligence. So emotional intelligence was the first introduced by Daniel Goleman in 1995, and he wrote a book on it as well, if you want to read more about it. He mentioned that emotional intelligence plays a vital role in our growth, and we need to know about it, and it is as important as IQ. And the terminology is using EQ. So EQ versus IQ, so both are very vital in our growth. And one study mentions that we have 27 emotions that we need to manage on daily basis and to keep ourselves healthy. And there are 7 universal emotions like happiness, sadness, anger, fear, surprise, contempt, and disgust. So these are the 7 universal emotions. So let's go briefly about emotional and brain anatomy, as we discussed last session as well. So brain has 2 cerebral hemispheres. Each cerebral hemisphere has 4 brains: frontal lobe, temporal lobe, parietal lobe, and occipital lobe. And you will see this small portion over here is amygdala. So that is involved, is a part of the limbic system. And this limbic system includes hypothalamus, hippocampus, septal area, and limbic cortex, along with the amygdala. And these control all our emotions. So there are 2 amygdalas on each side of the brain, and each amygdala is located close to the hippocampus in the frontal portion of the temporal lobe. And as mentioned, amygdala manages our emotions, and the large portion of the brain is called the cerebral cortex, that is called the rational mind, and it helps us on our critical thinking. So when we are in an emotional state, our emotional mind hijacks our rational mind thoughts, and we cannot think clearly when we are angry. And it's very important to understand your emotional state to manage it with your emotional intelligence. So emotional intelligence has the 4 skills. They have 4 domains as well. So first of all, self-awareness. What does that mean? We call self-actualization, know yourself. This means you must be aware of your emotions, your motives, you recognize yourself, and know your strengths and weaknesses, know your confidence level, do accurate self-assessment on a daily basis, look on your weak areas and keep improving yourself. And self-management, we can call it self-regulation as well, or self-discipline, and be persistent in the face of frustrations, recognize your emotions. And another aspect is adaptability. It means you are capable of adjusting yourself to new situations or any new conditions that come across. And also take the initiatives. It's the ability to assess, initiate the things, or start any new projects, include your ability to motivate yourself to achieve your goals. And self-motivation is very important. And also learn anger management. We all get angry here and there. There are a lot of anger issues at workplace, among colleagues, students. So learn how to manage our anger. It's very important. And because anger is a very strong emotion, it's full of energy. So we have to channelize our anger emotion for constructive purposes. So you need to learn how to channelize. And first of all, you need to understand it, how it's happening, why it's happening, what's the underlying cause. So as I mentioned, the amygdala is the small almond-shaped portion that manages all our emotions. So make sure we are not getting hijacked by that, and we manage our emotions. And there are different coping mechanisms that you can apply and adapt in your life that can help you with your anger management. And the third skill of emotional intelligence is social awareness. This means understanding of others, having empathy for others, meaning you have the ability to understand and share others' feelings as well. It also includes service orientation, community services, help others at your level best, add values in others' lives. Even if you can help one person, it's a great achievement. It doesn't matter if kindness is small or short, just try your best, whatever you can. And this is how you can help others and have social awareness. And the last emotional intelligence is relationship management. Is one of the big issue these days worldwide. So we need to learn the relationship management. What does it mean? Handling the relations appropriately, your ability to manage relationships. Important skill to keep up with relations is communication skill. So we need to improve communication skills, be assertive. There's always conflicts, so learn how to manage the conflicts, learn how to resolve the conflict, and collaborate with others and work together as a team. As said, together everyone achieves more. TEAM, together everyone achieves more. So emotional intelligence, learn more about to respond appropriately, not react aggressively. So emotions are very contagious. For example, I shared last time as well, that if a baby smiles, we start smiling as well, right? If someone is angry, we get angry as well. So they're very contagious. So just keep an eye on it and manage your emotional intelligence and learn more about it for your self-care. All right. So next, intellectual intelligence, IQ. So we all know about IQ, right? We have it means, what is IQ? It means the capacity of learning, capacity of reasoning, understanding. Is basically the manifestation of higher faculties, higher mental capacity, the cognitive skills, your mental capability that involves the ability to reason, ability to plan, ability to solve the problems, think analytically, think outside the box, and learn quickly, and to produce beneficial results for yourself and for community and overall for humanity. So let's quickly review anatomy again to understand better. There are different lobes of the cerebral cortex. Each lobe has its own function. So frontal lobe, parietal lobe, occipital lobe, temporal lobes. I'm keep repeating over and over again, so it will be at your hippocampus, it will be engraved. So 4 lobes, the area of the brain, rational and logical thinking. So these are the frontal lobe. So there are different IQ tests available these days, and there are these days commonly used test is called WAIS, And average IQ is between 85 to 150, and the score of 135 or above puts a person in the 99th percentile of the population. And I was reading that Einstein had IQ of 160 or above. And there are different tests assess your intelligence on different levels of thinking, and it examines different faculties of the brain. And the four main areas that we need to discuss is a verbal intelligence, logical reasoning, your working memory, and the processing speed. And I would share that IQ, some people have high IQ levels, but I can share one of my family member, she has very high IQ level. We had a psychologist test for her, and she was the top 2% population. But if she will not work hard, she will not put effort, her intelligence will be of no use. So it's very important. It doesn't matter if high IQ or low IQ, if you put effort in it, be persistent, you can achieve your goals. So let's pretty quick review verbal intelligence. What is this? It's the ability to understand and reason using concepts. Is basically the language-based reasoning. How can we improve it? Read, read, read. As widely as possible, learn a new word every day, become an active learner, keep a journal, play some word games, read quality articles, newspapers, and practice comprehension. So learn a new language, volunteer as a teacher, this is how you can improve. And of course, practice makes everyone perfect, right? Okay, very briefly, verbal intelligence is linked to the problem solving, is the abstract reasoning, working memory as well. So critical thinking, abstract reasoning, these are all come inside under this. And we analyze based on the facts, based on data, based on evidence. So related to those of our situation. So it includes observation, includes your analysis of the situation, interpretation, reflection, evaluation of the facts and data and evidence related to that. It will help with the problem solving and informed decision-making skills. And you can make the best decisions based on your ability. And how we can improve it? Become more self-aware, know your weak areas, understand your mental process, try to understand the basic anatomy and physiology of the brain, practice active listening, ask questions. It will help you to improve your reasoning skills. There's a very good book I can recommend for you. It's called Teach Yourself to Think by Edward de Bono. It's a really good book. If you want to learn more about it, to polish your critical thinking skills, it will help you. And working memory it's a means of holding the information in mind while performing relevant tasks. How can we improve it? Breaking big chunks into small ones, and use a checklist for tasks, develop a system that will help you to retain the information. Last but not least, practice. So there are two different methods of memory I can share. One is called the mind map. It was given by Tony Buzan. It's really good way of mind mapping. This is how you can memorize the stuff. And other one is the SQ3R method. It has 5 steps: read, recall, survey, overview, survey, query, and review. So next quadrant I want to talk about pretty quick. So again, the processing speed in the IQ. So it's one of the most important element of intelligence. How we process the information is the pace at which you take the information, make sense of it, you process it, synthesize that knowledge, and begin to respond to that information intelligently. And how we can improve it? Again, train the brain. And how we can do that? By practicing skills, work on your visualization skills. Most of them has a more visual memory, better than auditory, and try games that will help you with your visual memory. And in a nutshell, IQ can be improved. So it's not just a genetic, as I mentioned before. So please try to understand learning something new every day. It can help you improve your IQ, reading books, learning from your mentors, add mentors in your life, learn from your teachers, make a habit, be a lifelong learner, enroll in online courses. There are many free online courses available these days, read quality articles, and whenever we learn something new, our cognitive ability curve goes up. So in medicine, you will need to learn a lot of concepts. And beside concepts, there are a lot of reasoning and memorization as well. So please start practicing these basic concepts, and they will help you to improve your skills, and it will help you with your standardized testing scores, and it will help you in your achieving your goals. And last quadrant of your self-care is a spiritual well-being. What is that? What is spiritual intelligence? It's the capacity of human being to know your purpose of life by self-understanding and having a high level of degree of compassion, of human values. It's basically acknowledging your morality, your moral values, your thinking process, what you can offer to the humanity. It's living in humility, bearing in mind that you are just a tiny component of this universe. Be humble, live simple, be beneficial for others, add values in others' life, fulfill your social responsibilities. And last but not least, attitude of gratitude. As I mentioned last time, uh, that attitude of gratitude is very important. Count your blessings. And uh, spirituality is basically your spiritual care by asking yourself your meaning of life. Look for a deeper meaning. Think positively, be optimistic, have your prayer time, try some yoga, some meditation, travel, uh, adapt, attitude of gratitude. And as I mentioned, is a spiritual intelligence, attitude of gratitude is one of the component. So count your blessings. So sometimes don't take blessings for granted. As I mentioned during last sessions as well, many people are dreaming for what we already have. Many people cannot see, we can see. Many people cannot hear, we can hear. Many people are striving for food and shelter, but we have, right? So many people didn't wake up this morning, but we all woke up this morning, right? We are breathing. So please count your blessings every day and inhale and exhale with gratitude. So your spiritual well-being is finding your why. So in every aspect, whatever you do, say, ask yourself why I'm doing it. And that's the main thing. It will help you to find your purpose of life. So I will just conclude all this self-care. So all four domains of the well-being are self-care. They are interconnected. So please make a habit to take care of your well-being. Lastly, I would like to share that you should, why I'm stressing on it, because you are the future of medicine. You are going to be the leaders in medicine. You are going to do innovations, find new ways of managing patient care, right? So you are young minds with full of energy. If you will not be able to help your well-being, yourself, your health, how you can help others, how you will serve humanity, how you will add values in others' lives. So please make a habit of taking care of your well-being, and by adapting healthy habits, you can avoid a burnout and keep yourself healthy to achieve your goals. And lifestyle medicine is all about control of yourself, your well-being, and improve your health. And finally, please be physically healthy, be emotionally sound, be intellectual by learning something new, and find your purpose of life, find your why. All right, so let's take a real ride of internal medicine now. So I would like to share another video for fun. Why do I want to be a doctor? Let's see if you will like it. So let's see, watch the video again for
Everyone, my name is Nora and I am 4 years old. Welcome to Nora's Talk Show. Let me tell you what I want to be when I grow up. I want to be a doctor. Why do I want to be a doctor? Because I can help people. There are other jobs to help people, like teacher, firefighter, chef. But if I'm a doctor, then I can learn about myself, like anatomy, physiology, pathology, and medicine. To be a doctor, we have to study and work hard. Practice makes perfect. Come back for more Nora's Talk Show. See you next time.
All right, I hope you enjoyed it. Okay, so I just want to make you relax before we take a real ride of internal medicine. I understand we have students from high school, undergraduate level. We have international medical graduates as well. Already taken USML exam. So I will try to have everyone learn from this sharing session, and I will try to explain a few medical terminologies as well. So let's see, what do we know about? So last week, last sessions, we had a word cloud. What do you think when you hear internal medicine? So we made a word cloud last session. I'm going to skip this part, but I will just quickly, briefly go over. Internal medicine is a field dealing with diagnosis, medical conditions, treatment plan, and prevention of diseases, and compassionate care of the adults. And the physicians specializing in internal medicine are called internists. And the most fascinating part of internal medicine to me is to diagnose and manage patient involving all the organ system and a broad spectrum of health issues, and are specially trained, and we are specially trained to manage seriously sick patients. Like we have rotations in ICU and CCU, and we have a training in the preventive medicine and the preventions. So typically internists, like we perform physicals, we manage illnesses through medications, we manage through non-invasive methods, we manage through lifestyle medicine, lifestyle modifications like diet, exercise, patient education, and counseling. So while doing telemedicine residency, you come across different rotations. We have rotations on the medical floors. We can see cases like UTI, complicated UTI, cellulitis, pyelonephritis, all these cases. Then we have urgent care rotations. We have ICU, medical ICU, where we can see the CS stroke patients. We can see septic patients in ICU. So then CCU is a cardiac care unit where we see the myocardial infarction patients. And the emergency room rotation we have, so we can have an idea when patient comes in, how we manage the patient. Then we have an outpatient rotation in clinic settings, excuse me. And then we have electives. We have rotation in cardiology outpatient, nephrology, neurology, and dermatology. So these are the electives we can have during our internal medicine residency rotation. Excuse me. So once we complete the training, we can manage patients both inpatient and outpatient. And the inpatient care settings, as mentioned, is a hospital care setting, and outpatient care means we manage the patient in office setting. And the acute conditions we manage in the hospital setting. So acute conditions, basically, sometimes we can manage office setting as well. So acute conditions are severe and sudden in onset in illnesses that develop suddenly and last for days or weeks, like appendicitis, like fracture of the bone. So those are sudden in onset, but some conditions that are sudden in onset but was not severe, that we can manage in office setting. But the conditions who are sudden in onset and severe in nature, that need to be need hospitalizations. So acute or chronic conditions are not necessarily fixed. So like chronic conditions are the long lasting, they develop and potentially worsen over time. And chronic conditions are long developing syndromes that develop over a certain period of time. And chronic conditions like persistent or long lasting in the effects, like osteoporosis. And so as mentioned, acute and chronic conditions are not necessarily fixed. So acute conditions can sometimes become chronic, while a chronic condition may suddenly present with acute symptom. Like if we don't manage acute renal failure properly, it can go into chronic kidney disease over a passage of time. And like asthma attacks. So if we persistent, it can develop into chronic obstructive pulmonary lung disease. It can become chronic. So this is how acute and chronic we can differentiate. We can manage acute conditions in the office setting as well. The simple one, like a simple UTI, we can manage. Simple cellulitis, we can manage. But if patient has a severe pyelonephritis, patient had nausea, vomiting, they need IV management, then patient need to be admitted to the hospital. So this is how you need to understand. This is all the clinical judgment. The patient need to be admitted, managed as an outpatient setting, or patient need hospital admission. Okay, so the most, I'm going to go over pretty quick about, again, inpatient and outpatient cases. Again, is the most common cases I'm sharing with you. It's not limited, excuse me. During residency training, you will see more cases. And I'm just discussing very few most common cases, which will come across while you shadow any physician. Excuse me, I will go over with you very briefly. Okay, so first of all, I'm going to go over neurology cases. It's a branch of medicine dealing with disorders of the nervous system, like central nervous system, peripheral nervous system, blood supply of the brain. And inpatient care, we do stroke patients who have ischemic stroke, hemorrhagic stroke, then transient ischemic attack called TIA. And outpatient care, we can headaches, migraine headaches, dementia, major depressive disorders, ADHD, bipolar disorder. So these are, we can manage as an outpatient. Next, cardiology, branch of medicine, manage disorders of the heart. Most common cases we do manage, and you will come across while you're shadowing In patient care, we see the coronary artery disease, myocardial infarction, in other words, heart attack, CHF, congestive, AFib, atrial fibrillation, then hypertensive urgency, hypertensive emergency, syncope. In outpatient care, we manage essential hypertension, hyperlipidemia, coronary artery disease, CHF, and AFib. So when patient has these acute conditions of myocardial infarction, they need to be on medications that can be managed in outpatient care setting. So this is how they can have follow-up with the family doctor, with the primary care doctor, and with the cardiologist. So this is how we can manage in the outpatient care. So next we have pulmonology. It's a branch of medicine, manages diseases of respiratory system. And as I mentioned before in previous sessions during this pandemic, the critical care patients managed by the pulmonologist who needs to be on the ventilator support. And after internal medicine residency, you can have 3 years of pulmonary and critical care fellowship. Then you can manage your patients in ICU as a pulmonologist. So inpatient care, in the hospital setting, we see the COPD flare-ups, asthma attacks, and the lung infections. In outpatient, we can manage asthma, pharyngitis, bronchitis, COPD, mild COPD that doesn't need inpatient care. We can manage as an outpatient setting, and lung infections as well. So next we have a gastroenterology. It's a branch of medicine focused on digestive system and its disorders. And outpatient care, GERD, dyspepsia, irritable bowel syndrome. Inpatient care, upper GI bleed, lower GI bleed, pancreatitis. It means inflammation of pancreas, cholecystitis, inflammation of the gallbladder, colitis, inflammation of the colon. So these are the inpatient care we can do based on their patient situation. All right, so next we have nephrology. It's a branch of medicine that deals with the study of kidney function and kidney diseases. I know, again, I'm giving you too much information. It will be overwhelming, but again, bear with me. I'll keep repeating over and over again. So cases we manage: acute renal failure, hyponatremia means low sodium level, hyperkalemia means elevated potassium levels, diabetic nephropathy, and nephrolithiasis means stone in the kidneys. Next, we have endocrinology. It's a branch of medicine dealing with endocrine system, its diseases, its specific secretions known as hormones. And the inpatient care, we can manage poorly controlled diabetes and DKA, called diabetic ketoacidosis. And outpatient care, we manage diabetes mellitus, hypothyroidism. So the little correction here: hypothyroidism is a low thyroid hormones and high TSH level. So this is last time I said high TSH. It's not high TSH. It's not low thyroid hormones and high TSH in hypothyroidism. Then we manage vitamin D deficiency, obesity, overweight, osteoporosis, and PCOS. Next, we have infectious diseases. Again, disorders caused by organisms such as bacteria, viruses, and some infections are contagious and can be spread from person to person, like this pandemic, unfortunate situation for all of us worldwide. And inpatient care, we have lung infection, urine infection, cellulitis, osteomyelitis, and outpatient care. We can manage same conditions, but it depends the severity of the patient presentation. Then next we have dermatology. It's a branch of medicine dealing with skin diseases, and we can manage dermatitis, atopic dermatitis, acne vulgaris, onychomycosis, skin and soft tissue infections, bites, and infestations. And then we have hematology. It's a branch of medicine deals with the study of and causes of studying causes of treatment, prevention of disease related to blood. And we can manage anemia, means low hemoglobin level, thrombocytopenia means low platelet count, and leukemia. So next we have rheumatology. It includes bones, muscles, tendons, ligaments, soft tissues. Inpatient care, any bone fracture, any joint replacement. We need orthopedic surgery help in that. Internal medicine and orthopedic surgery teams can work together. They can work side by side, and this is how we can manage. And outpatient care, and sometimes orthopedic have their own floors, so they can manage themselves. So they don't need internal medicine, but sometimes if they need help, they can consult the internal medicine and they can help you with their medication management. In outpatient care, most common cases we see the back pain. They have most patients present with the shoulder pain. They present with the osteoarthritis. They have gout arthritis and fibromyalgias. And then we can manage outpatient as the ENT cases and ophthalmology cases as well. So otitis externa, infection of the outer ear, otitis media, infection of the middle ear. Then we can manage rhinitis, sinusitis, tonsillitis, and ophthalmology cases that we can manage as an outpatient, conjunctivitis, STI, dry eye, and blepharitis. And next we have a general medicine, how we can falls, inpatient care, metabolic encephalopathy, arthritis, outpatient care, again, backache, anxiety disorders, depressive disorders, malaise, fatigue, bipolar disorders, OBGYN, like cervicitis, we can manage, STDs, we can manage as an outpatient, and prevention part. So prevention part, we do the, for prevention part in inpatient, we can prevent any falls while patient in the hospital. We can prevent any decubitus wounds. We can make sure patient is on appropriate diet, like renal patients on dialysis need renal diet. Diabetes patient need carbohydrate control diet, and we can prevent the clot formation while patient in the hospital. We can start some DVT prophylaxis to see how we can do prevention part. In outpatient care, we do the immunization for adults, and then disease screening we can do, like pap smears, mammogram, colonoscopy. These are all the screening that we can do as an outpatient. And then counseling is very important, smoking cessation, overweight, lifestyle modification, lifestyle medicine, we can do as an outpatient. Follow-up examinations we do routine health maintenance, adult wellness exam, and pre-op risk assessment we can do. All right, so let's see. So let's review the cases again, and I will present new case today. So hospital care patient, as I mentioned, last time we discussed about the stroke patients. So come on, let's start doing the cases again. Okay, all right, so first, before going over the cases, let's go over the bedside manners. It's very important. We need to make sure we have a good communication skills. And all right, so bedside manners is very important. Communication skills, active listening, listen to your patients. So patient tell you the diagnosis. When you listen to the patient, they tell you all the history. I will go over pretty quick as well. I think I have my slides over here. I will go over pretty quick. So communication, active listening, they will tell you the diagnosis. And then of course you will ask open-ended questions. Be compassionate, show real genuine concern about their problems to help them. And have honest discussion about their problems and try to solve as your level best. And make sure you have at the patient, if patient is lying down, so take a chair, sit at the patient level, so you have the same eye contact level. You will learn more about patient bedside manner. Is very important for patient care. All right, so I'm going to go over briefly about the history first, history exam and diagnostic tests we do. I'm going to go over. Let me pull up. Okay, so before discussing the case, I'm going to go over briefly history taking. So in the history taking, first of all, patient present with a chief complaint. What is the main concern? Like a patient say, I have a chest pain. So that's considered chief complaint. And then we say history of present illness. What does that mean? So we get more detail about that chest pain, about that chief complaint, what happened, when it started, for how long he has pain, how severity. So these are all any radiation pain, any elevating factors, any aggravating factors. So these are all the questions we ask the patient, and history of present illness, we get more detail about it. If patients present with two complaints, so we get both in the chronological order, which one started first, what happened next. So this is called history of present illness. Then review of system. We do head to toe review system. We ask all these questions, say all other review system is positive or negative. Then we ask for the past medical history. patient have any medical history in the past. Then we ask about any allergies, any medication allergies. And then we ask about social history. Patient, any drug history, any alcohol consumption, smoking history, the profession we can ask. Then we have family history. Family history means anyone in the family, the siblings, their parents have any medical conditions. Then we ask about medication history. Are they taking any medications at home? Any over-the-counter medications? For how long they're taking it? So this is all the brief preview I'm going to give you about history taking. Then after history, we take through the examination part. So the physical examination, again, we do head-to-toe exam. We first of all, we do assess the general, how they look like. They are awake, alert. They're generally how they look like. Then from head examination, ENT, ear, nose, throat, we examine the eyes, we examine the neck, we see the cardiovascular system, we examine the pulmonary system. So we go over next session one by one. I'm just going to give you a quick snapshot of what we do in the physical examination. Then gastrointestinal exam, that means abdominal exam we do. Then musculoskeletal exam we do. Then we, it's up to any condition, genitourinary exam, we need some chaperone. We cannot do, we need some chaperone to do this exam. Then neurological exam, then skin assessment, and then psychiatric assessment. These are all complete physical exam we do. And then after examination, we do the diagnostic workup. So different tests we do. I'm just gonna give you brief, basic tests we do. Just give you a brief idea what we do the diagnostic workup. CBC, complete blood count. We check hemoglobin, platelet count, and WBC. CMP, comprehensive metabolic panel, is all the chemistry we check. Sodium, potassium, different chemistry of the body. Then lipid panel, cholesterol level we check. A1C is the test we do for the diabetes, how they're doing. If they have diabetes, A1C number will tell us. Then TSH, thyroid stimulating hormone, and free T4. These are the tests we check for the thyroid function. Then EKG is electrocardiogram, we check. Then urine analysis. On the imaging side, we do the X-ray, we do ultrasound, we do CT scan, MRI, we do the PET scan, then ERCP. So these are all the basic. I'm just gonna go over this with you, diagnostic workup. Sometimes in the next sessions, we can talk more about it. All right, so let's go to the medical floor. And after all this history, field exam, diagnostic workup, we do the assessment plan. So based on all this, we do we diagnose the patient. Then we rule out the differentials based on our workup. Then we start some medications, or we see, okay, patient doesn't need medication, patient doesn't need lifestyle modification, or they just need the counseling. So this is how we make the assessment and plan. It's all the clinical judgment that you will learn during residency. All right, so let's go to the medical floor and discuss our first case. So we'll make a word cloud for this as well again today. So this patient is a first case, 60-year-old gentleman is brought to the emergency department by the family with complaint of slurred speech and right arm tingling sensation with some weakness while he was reading the newspaper early this morning on their way to the emergency department. But when he was in the emergency department, patient is back to baseline. His all symptoms have been resolved. So again, we do the review system from head to toe. Then we see as well allergies, any past medical history, any medications patient is taking. Then we go over the patient social history, then family history. So in this case, patient is an ex-smoker and quit 5 years ago. And family history, patient has a family history of coronary artery disease, and the mother had a diabetes. So next, I'm going to give you examination, and then we'll go open the differential diagnosis word cloud for you. So on examination, I'm going to give you vitals, blood pressure 138/88, almost normal, pulse 82, respiration 16, temperature 98 Fahrenheit, oxygen saturation 98%. And from head to toe, I'm going to skip that part. Neurological exam, we assess patient alertness, patient orientation. So patient was awake, patient was alert, orientation times 3. We check the strength. It was 5 out of 5 in all extremities. So on the neuro exam, we check mental status, we check the cranial nerves, we check the motor system, we check a sensory system, we check reflexes, we check the tone, we check the coordination, gait. These all come in neurological examination. So I'm just giving a specific neurological examination in this patient. So let's see the differential diagnosis. So what do you think? What is a differential diagnosis?
Thank you, Dr. Chima. I just placed a link in the chat where people can answer what is the differential diagnosis of this patient.
All right, good. Ischemic attack, transient ischemic attack, stroke. Any high school student, you can mention which system we are talking about this patient. Okay, good. Nervous system. Okay. All right, good. This is good. All right, so you guys know. Great. So we have a good. So we have developed differential diagnosis. So diagnosis. Okay, so I was muted somehow. Anyways, okay, so in this case, you guys are right. It's a stroke, TIA, transient ischemic attack, and nervous system is involved. And when patient comes with altered mental status, we just don't know more history. So we can say, okay, it can be stroke, it can be CVA, delirium, metabolic disorder can cause it, like high ammonia level can cause it, any infection can cause it, epilepsy, hypertensive encephalopathy, any medication can cause it. So these are the differentials we can create, just thinking about altered mental status patient had. But in this case, we had the detailed history, we had the examination. So we know that patient had more towards going towards a transient ischemic attack. So what is differential diagnosis? Again, it means there is a more than one possibility for patient's diagnosis. Excuse me. It's a process wherein we differentiate between two or more conditions that could be possibly causing patient's symptoms to determine the actual diagnosis. And it involves several diagnostic tests to rule out different possible disorders. And as we discuss different tests, we do the basic test. And then in this case, we'll do the CT brain. And for TIA, I will discuss more about CT scan after discussing the second case, more about it. Okay, so let's discuss the second case. So we have a patient, she's a 65-year female, brought to the emergency department by the family with complaint of slurred speech and right arm tingling sensation with some weakness while she was reading the newspaper early this morning. Again, we said she was reading the newspaper. Other patient was male, she's female. And in this case, patient is not at the back to the baseline. This case written is not appropriately. Patient with continued symptoms, and this is not the right, but in this scenario, 65-year female brought to the emergency department by the family with slurred speech, right arm tingling sensation, excuse me, with some weakness. And her symptoms are persisted while she was in the emergency department. In the first case, symptoms were resolved, but in this case, she has still ongoing symptoms. She still has symptoms. So we took the history. Patient has a history of hypertension, past medical history. Again, we do a review system. Patient has a history of hypertension. She's taking her medications. Family history has a history of stroke. And on examination, I will give you a brief exam on her. Vitals, blood pressure 180/105, pulse 82, respiration 16, temp 98, oxygen 98. And again, neurological examination, patient is awake, but she's confused. She has a slurred speech. Patient has a right upper extremity weakness and right lower extremity weakness as well. But in the previous case, I mentioned patient extremity, there's no extremity weakness. All strength is 5 out of 5. So this is how I'm trying to differentiate between this case and the prior case. So when we question the patient seems to understand what is being said, but she was not able to clearly respond. So she has ongoing symptoms. So what do you think is going on in this case? So yes, it is a slide. So in this case, differential diagnosis, again, TIA, stroke, nervous system. But the reason I'm bringing up these two cases back to back, so you can differentiate transient ischemic attack and CVA. So cerebral vascular accident, both we can differentiate. TIA symptoms were resolved by the time patient was in the emergency department. In this case, patient has ongoing symptoms. So this is how we can say, okay, this is not transient ischemic attack. This is something serious going on. We need to do workup. So what do we do? So first of all, this is CVA. What is CVA? So CVA is defined as a sudden onset of focal neurological deficit. It occurs when blood vessel that carries oxygen and nutrition to the brain is either blocked by a clot or excuse me, or rupture by any blood vessel rupture there in the brain. And that part of the brain cannot get the blood supply, and the oxygen it does not fulfill the oxygen needs. And that's how brain cells die, and they have ongoing neurologic deficit. So that's why it's called CVA. So we have to figure out is ischemic stroke or hemorrhagic stroke. I will go over pretty quick. Let's go over brief anatomy again of the brain. Again, two cerebral hemisphere, right and left, and each cerebral hemisphere 4 lobes: frontal lobe, parietal lobe, temporal lobe, occipital lobe. So I remember I told you in previous session, I will keep repeating over and over again. So it will be engraved in your hippocampus. Okay, so next we am going to talk about the blood supply of the brain. Again, right cerebral hemisphere, left cerebral hemisphere, 4 lobes in each brain. And then anterior cerebral artery supplies the medial frontal and parietal lobes. Middle cerebral artery supplies the majority of the lateral hemisphere, and posterior cerebral artery supplies the medial and inferior temporal lobes and occipital lobes. And next, I'm going to show you the medial view. This yellowish part you can see is supplied by the anterior cerebral artery. This blue section, posterior cerebral artery. And the lateral view, major part of the brain is supplied by the middle cerebral artery. So I told you 2 cerebral hemispheres, right and left. So this is how you will have a right anterior cerebral artery, left anterior cerebral artery, right middle cerebral artery, left anterior cerebral artery, right posterior cerebral artery, left posterior cerebral artery. So this is how you will remember. Okay, so next I'm going to show you, excuse me, all right. So in this case, patient present with a neurologic deficit, we do the CT scan. And what is the CT scan? So CT scan is basically medical imaging that is used to get detailed images of the body for diagnosis. And CT brain, it provides more detailed information about brain tissue of the brain and the brain structures that I talk about, lobes, and we can see any ischemic or hemorrhagic changes. Excuse me. And I will excuse me. What is ischemia? So it is an inadequate blood supply to any organ or part of the brain, part of the body. And in this case, it's the inadequate supply of the brain. And what is hemorrhage? An escape of the blood from a ruptured blood vessel, as it can happen to any blood vessel in our body. But when it happens to the brain, it causing bleeding in the brain. So in this case scenario, it can be a hemorrhagic stroke or hemorrhagic CVA. So that's I was talking about. So I talked briefly about CT scans. This is a normal CT scan. And we can see that, go back to the slide. So this is the normal CT scan. So bone absorbs the normal X-rays. So the skull, the white portion, you can see the skull that appears white on the image. And the water in the cerebral ventricles, or called the fluid-filled cavities in the middle of the brain, absorb little and appears black. So this is how you can see in the middle, little darker areas. So most ischemic strokes are less dense, means they are darker on the CT scan. And then the normal brain, I will show you comparison between normal brain and ischemic brain. And the blood in the hemorrhage is denser, and it looks white on the CT scan. So this is how I can show you next image, the normal. So you can see in the right, the image is the normal image, and the left is a hemorrhage. So this hemorrhage is on the right cerebral hemisphere. So this is the right middle cerebral artery hemorrhage. So it's a correction. So it's a right middle cerebral artery, and this is the right cerebral hemisphere. You can see this whitish area. So this is the hemorrhage. Next, I'm going to show you ischemic stroke. So this is normal, and this is darker area over here, right? And this is anterior, this is left anterior cerebral artery infarction. So this is not a hemorrhage. So now you understand the difference between ischemia and hemorrhage. So ischemia was darker in color and hemorrhage was brighter, whiter in color. So this is left anterior cerebral artery infarction, and previous one I showed you hemorrhage was a left middle cerebral artery, because I showed you the diagram before that middle cerebral artery supplies the lateral view, most portion of the lateral view. Okay, so next, this is I showed you. So this is, again, you can see the brighter area is a hemorrhagic stroke. Okay, so now I hope you understand difference between the transient ischemic attack and stroke. The transient ischemic attack, patient had the symptoms for a short period of time, and then stroke, patient will have ongoing symptom, ongoing neurologic deficit, and then we get a CT scan and we differentiate whether it's ischemic stroke or hemorrhagic stroke. So this is how you can differentiate on the CT scan what is ischemic stroke, what is hemorrhagic stroke. And then I'm going to go over the next case now. Again, the stroke patient, some hospitals have a stroke unit. So patients are admitted in the stroke unit. They don't need to be in the medical floors. And some hospitals, they don't have a stroke unit, so they admit it on the medical floors, and the internist can follow up. And of course, they consult the neurologist as well. They get their consultation and get their help as well, and they're on board with us. So you need to understand that some hospitals, the university hospitals, where I got training in Chima General Hospital, they had a stroke unit over there. And all the stroke patients were admitted in the stroke unit. And the other hospitals, like community hospitals or other hospitals that don't have facility for a stroke unit, they admit in the ICU or telemetry floor or medical floors. Basically, they go on the medical floor, but we do the tele on floor because we have to monitor their heart rate. We need to find the cause of the stroke. So we put them on the medical floor with telemetry on it. So this is how you can say, okay, what a stroke unit means. So this is how you can say, okay, if hospital doesn't have a stroke unit, so this means they will be admitted on the medical telemetry floor, or if there's really patient is really severe condition, the patient will admit in the medical ICU setting. So this is how you will understand between how we will admit the patient. Okay, so now next case. So this is a 57-year-old female comes to the emergency department complaining of chest pain that woke her in the early morning. So again, we do a review system, head to toe, past medical history. Patient does not have any major physical illness in the past. She's not taking any medications. And again, I'm gonna briefly go back to my second case. I showed you the high blood pressure. Patient blood pressure was high. I make it a red in color. So that was, in that case, it was a hemorrhagic stroke, but I showed you the comparison in both. So you can compare. The case I presented was a hemorrhagic stroke because the blood pressure was high. It has a ruptured vessel. And this is how patient had all the symptoms. And then, so I show you a difference between ischemic stroke and hemorrhagic stroke. And now move on to this case. 57-year-old female comes to the emergency department complaining of chest pain that woke her up in early morning. So review system head to toe, past medical history, no major illnesses, medication, she's not taking any medicines, family history, no history of coronary artery disease, social history, no history of drug abuse, smoking, she drinks alcohol socially. I'm going to give you examination. Again, vitals pretty much normal. Blood pressure 126/78, pulse 78, respiration 714, temperature 98.6 Fahrenheit, oxygen saturation 97%. So again, head to toe exam. Then I'm going to give you cardiovascular exam in this scenario. So patient has normal S1, S2. Patient has normal sinus rate rhythm. There's no murmur appreciated. So on cardiovascular exam, we do the inspection, palpation, and auscultation. This is how we do the cardiovascular. First of all, we look how chest looks like. Then we palpate for the PM called PMI. I will explain sometime later. I don't want to confuse you at this time. And then we do the auscultation, where we listen with a stethoscope, heart sounds, any murmurs. This is how we listen via auscultation with a stethoscope. So we did the EKG on this patient, and patient has a ECG that reveals the sinus rhythm. Of course, we did all the blood workup. We did the cardiac enzymes on her as well. So ECG reveals the sinus rhythm with ST segment elevation. Some point I will discuss with you EKG in detail. Then we will see what does that mean, ST segment elevation. There is a PQRST. I will have shown you EKG pretty quick. I think I didn't add my slides in it, but I will show you next sessions. ST segment elevation. So now I'm going to open the word cloud again. Tell me, what do you think is the differential diagnosis?
Thank you, Dr. Cheema, again. I placed the link in the chat again, which will take you to the word cloud website, and you can enter your answer in. What do you think the differential diagnosis of this case is?
Okay, good. Someone say ST elevation MI called STEMI, myocardial infarction. Good. Let's see if we get more responses. Okay, all right. So let's move on. You guys are right. It's a myocardial infarction. It's a coronary artery disease. So what is myocardial infarction? What is coronary artery disease? So let's go over brief anatomy of the heart first. So heart has 4 chambers: right atrium, left atrium, right ventricle, left ventricle. So these are the 4 chambers of the heart. And then we have the blood supply of the heart, because we have to see what's going on, what happened, why this patient had the myocardial infarction. So this is the inside of the anatomy of the heart first. You can see left atrium, left ventricle. There's a valve in between left atrium, left ventricle. On the right side, right atrium, right ventricle, there's a valve called tricuspid valve. The valve between the left atrium and the left ventricle is called mitral valve. So 4 chambers: left atrium, left ventricle, right atrium, right ventricle. The valve between the left atrium, left ventricle is called mitral valve. The valve between the right atrium and right ventricle is called tricuspid valve. Okay, so next we're gonna talk briefly about the heart, blood supply of the heart. So the main arteries that supply the heart, so heart is a pump, but heart itself needs the blood as well, right? So heart provides the blood to all the organs, like it's a pump for our body, but heart itself needs the blood. So they're the coronary arteries. They call the coronary arteries that supply the heart muscle. They're called myocardium. So there's a left coronary artery, right coronary artery. Then other branches are left anterior descending artery, left circumflex artery. So I just want to give you, I will not go in more detail. I will just stop here. So main, you can say left coronary artery, right coronary artery, left anterior descending artery, and left circumflex artery. You will learn more in detail about anatomy, physiology during your medical school. And I'm just going to give you a brief anatomy, but I will go over again in my next sessions. So it will help you to learn about these name of the coronary arteries. Okay, so next, I'm going to show you. So in this patient, you guys figured out the patient has a MI, myocardial infarction, some coronary artery disease going on. So when there's a coronary artery disease, it can be myocardial infarction, it can be angina, stable angina, unstable angina, Prince-Metal angina. So there are different types. I don't want to go in detail. I will not confuse you in this. So, but when patient comes in, so we do the basic test, EKG. So then we do the angiography. So who does? Cardiologist. So we call the cardiologist. It's not internist, it's the cardiologist. They do the angiography. So I just want to show you this picture over here, this diagram, so you can see the normal coronary arteries. Before I show you the diagram of the coronary arteries, so over here you can see normal coronary arteries on the left side of the heart, and then normal coronary arteries on the right side of the heart. So these are the normal. So what happened with the patient? So next I'm going to show you. So you can see normal, and then you can see the blockage. So the coronary arteries that's supplying the heart muscle is blocked. That's why patient has a chest pain. So you can see over here this blockage, right? There's some stenosis going over there. There's obstruction of the blood supply to the heart. So this blockage there that caused the patient chest pain symptom. Then patient presented and we did EKG workup and we figured out, okay, patient had a blockage there. So this is how we figured out why. So now I'm going to talk briefly about what is myocardial infarction. So myo means muscle, cardio means heart, and infarctions means cut down blood supply. So myocardial infarctions, this means the blood supply of the heart has been cut off. There's a blockage there, some clot there that's causing this blockage, right? So you can see in this diagram, there's a blocked coronary artery and the heart muscle, myocardium. Myocardium means muscle of the heart is not getting the blood supply, is not getting the oxygen. That's why patient has a chest pain. So chest pain is a symptom that muscle is crying, heart is crying that I need oxygen, I need blood. So heart muscle is dying. So that's the symptom patient presenting, right? So any chest pain, don't ignore it. It's a red flag. So chest pain, heart muscle is dying. And the time is a muscle. We have to be very vigilant. It's an emergent situation. Right away, we call the cardiologist. If a patient, they come in right away. If they're on call midnight, they come right away. Some interventional cardiologists on call all the time. They come in, we have to do angiography and then put the stent in if there's any blockage. So I'm not going to go in detail at this time. I just tell you what's going on with the patient. So you understand the pathophysiology, what's going on, what's causing this pain. So myocardium, blood supply is cut down. That's why it's called myocardial infarction. It's called coronary artery disease. Why? Coronary, this is the name of the arteries that supply the heart muscles. Okay. Next, I'm going to show you atherosclerosis. So this is a normal artery. You can see the normal blood flow, but over here, there's a blockage. So I'm going to talk about what is atherosclerosis. So it's a disease of the arteries characterized by the deposition of fats, cholesterol on the inner walls of the arteries, causing the narrowing of the blood vessels. So when there's narrowing of the blood vessel, it causes obstruction of the blood flow, right? Like a water pipe. If we squeeze, there is less flow of the water in there, right? So we are blocking where there's water pipe. So this is what's happening in the blood vessels. So when there's a blockage, there's obstruction. When there's obstruction, we are not, the heart muscle is not getting enough blood supply and not getting enough oxygen. So that's why the patient has a pain, chest pain, and this blockage is causing all these symptoms. And what are the causes? So we have to treat underlying cause. So first of all, history, exam, test, workup, we do differentials, we rule out the differentials, we make the diagnosis. So then we see what is the cause? What's causing is this atherosclerosis, right? So then I'm going to talk briefly about the causes. So we have basically the risk factors for the atherosclerosis. So there's a constitutional factors like genetic. That's why we ask the patient about the family history. Their parents have the heart disease. Their patient had the stroke. So this is how we ask why we ask the family history. Then age, then gender. These are the constitutional factors causing atherosclerosis. Then, of course, male gender is more prone towards atherosclerosis. Then there are modifiable factors. So modifiable factors are the hypertension, high blood pressure, hyperlipidemia means high cholesterol level, diabetes mellitus means high blood sugar level. That's why they are taking your oral hypoglycemics or insulin for your diabetes management. And then smoking is one of the causes as well. Then stress is another factor. And there are additional factors. I'm not going to go in detail. It will be for cardiology fellows, inflammation, and I just want to go over terminology, hyperhomocystinemia, metabolic syndrome, lipoprotein A, procoagulants. These are the other risk factors for the atherosclerosis. All right. So this is all about our case studies today. And so this will giving you this idea when you do any shadowing session in person, you see the different cases, different patients. So this I'm trying to do more interactive so you understand basics, anatomy, physiology, pathophysiology, what's going on, what are the causes, then differential diagnosis, how we rule out diagnosis, what work we normally do, and then how to manage. So I'm not going to go the management part, but I'm going to tell you we manage based on the evidence-based medicine. So I'm going to make the word cloud again. What do you understand by the evidence-based medicine? Okay, let's move on. I think we don't have much time left. We'll do some times in the next sessions. Okay, so evidence-based medicine is basically a judicious and explicit use of the current best evidence in making decisions, making clinical decisions about the care of the patient on individual basis. So we treat all the patient on individual basis. And the key components are basically the research-based evidence. That's why research is very important. Clinical research, I try my best to contribute as much as I can. And then it depends on the clinical expertise of the clinician, clinical expertise of the doctors, internists, cardiologists, and then, of course, the patient values, patient preferences. So these all contribute in the evidence-based medicine. Based on that, we make up the treatment plan and manage accordingly. And the goal of the evidence-based medicine is to integrate the experience of the clinician, the values of the patient, and the best available scientific information to guide the clinical decision in best care, patient care. And there are different resources available that we physicians use online, and I will like to share with you. So you will have a brief overview what we use normally. We use up to date. So basically it's the online resource that we use. It's an up-to-date system. It's electronical clinical resources, the tool for the physicians and patients as well. And that provides information on patient care. Basically it's a global community, and this is the resources we use. They have most up-to-date information on any new guidelines, new research. This is, it can help physicians and patients. And then we have another resource, PubMed is another resource for clinical research. Like you can search any new articles, any publications, we can look up on the PubMed. You can see any new publications on any topic you can find on the PubMed. The next I'm gonna share with you USPSTF. What is that? It's a US Preventive Services Task Force. What is that? Excuse me. It's a panel of experts in a primary care and prevention that reviews the evidence of effectiveness and develops the recommendation for clinical preventive services. So basically, remember I talk about prevention medicine. So this is how they provide us the guidelines about at what time, at what age we have to do the preventive screening, all the immunization, basically the preventive medicine, they helps us, and all the up-to-date information they have at the USPSTF. And then I'm going to discuss with you CDC. It's a Center for Disease Control and Prevention. It's the National Public Health Agency, and it's under the development of, it's under the Department of Health and Human Services, and we follow CDC guidelines for the most up-to-date information for best possible patient care. So these are all the sources, not limited to, I just give you the main ones that we do use, and it helps us to make the treatment plan, make the make the plan for best possible patient care. And why we need it, why we need evidence-based medicine. The reason is we are in the field of medicine. We are managing patient, we are doing patient care, right? We need up-to-date information, and we need to keep our knowledge up to date. We need to keep polishing our skills to provide best possible patient care at our level best. So as I mentioned, medicine is a lifelong learning. We keep polishing our skills. So it's very important, keep yourself up to date about patient for best possible patient care. And then I would say treat all patients as your family members, like how you want your family members to be treated, right? So you want best possible care for your patients. So likewise, treat all your patients like you think if they are your family members, how you would like to treat them, right? You want to have up-to-date information. You want to know the best possible care that you can provide your patients. So please make sure you, whenever you're in the medicine field, even medical school, even now, you can keep getting your information and keep yourself up to date. All right, so let's talk about briefly about the patient records. And when we talk about patient records, we must know about HIPAA. I already talked about in previous sessions, but I'm gonna go again, repetition for our prior students and for our students who joined us recently. Okay, so HIPAA is the Health Insurance Portability and Accountability Act. And the components of HIPAA compliance requires healthcare organizations to exercise the best practices to keep the patient data source, patient's data secure. It's very important that we should be aware of it. It's important when students come for shadowing, we make sure that we are following the HIPAA compliance and we follow the rules. And these days, I'm going to go over briefly those EMRs and EHRs available these days. Most of them are all HIPAA compliant EMRs available. And terminology we use, EMR is electronic medical record and EHR is electronic health records. And both EMR and EHR are basically the digital records of the patient health information. Basically, EHR is the digital records of the patient health information, and EMR is best understood as a digital version of the patient's chart that we see on daily basis that we document. So this is an EHR contains a patient's records from multiple doctors and provides a long-term view of the patient's health records. And there are different EMRs we use in the hospital setting and in the office setting. And there are many EMRs available like Epic. It's very user-friendly. I used it in my residency, and in a few hospitals, we still have Epic. Then we have Meditech, we have Cerner, we have ECW, it's for outpatient, practice fee and outpatient, and there are many more available we can use. So this is all. I just click the screen shot for you. And all right, so I will stop here. I just give you brief few cases, history briefly, a brief snapshot about HIPAA, about EMR. And now I'm going to talk about briefly next, your keys to success. I will discuss last time as well. Be proactive, plan ahead, prioritize. First things come first. Think what is important to you. And I shared last time a story that when I was in high school, one of my mathematics teachers shared with us to get something, to sacrifice something, that one of our friend didn't do her homework. And she was upset and she said, oh, I was watching a movie. And she said, okay, so you had a fun time, but you sacrificed your study times. That's why you didn't do your homework. And now you're in trouble. So now you prioritize what you want, right? So first thing first, perseverance is very important. I can tell you from my life experience, be perseverant, practice. There's no magic in this world. Everything is practice. Be passionate. Do whatever you like, whatever appeals you. And of course, never give up. And pretty quick about for clinical more exposure, you can, of course, we are limited these days about in-person shadowing. So you can look up for any clinical jobs for medical assistant or any internships like clinical research assistant. You can look for even you can available on, if you can find something online research like clinical, you can find online that will help you with medical terminologies. It will polish your skills with the medical terminologies. And you can find some medical scribe jobs. They're also available online if you are offering it. And of course, it's tough these days as well. And there's a very free online courses available to learn clinical terminologies. I heard one is available on Coursera. You can double check if it's still available. And again, whatever you do, longer is better than many. So whatever you're doing, keep on doing. Like I started my clinical research more than a decade ago, and I'm still doing it. I keep doing my publications. It's a contribution, right? Research is very important. So keep on doing whatever you're doing. And of course, prioritize. And at the end, I will like to share about one of medical missions we have pretty quick with you. These are the medical missions we do for the underserved community. This is one of the clinics here for all name overseas in Pakistan we're doing. And then we have an association of physicians called APNA. We have APNA chapters in DC, Maryland, Virginia area. We have physicians that we do free medical clinics. This APNA group also do the free COVID testing they were doing last year. They did a COVID vaccine. In fact, I heard they did last week as well. And also they do the food distribution in underserved areas in DC, Maryland, Virginia area. Of course, they have chapters in all over the state. So every state has their own chapters, but under the umbrella of APNA, this Association of Physicians. All right. So I'm going to show you a brief video with you. I'm going to share with you. So this is one of the free medical camp we did. And again, goal is serve humanity. And from Lord we receive, to humanity we give back, we give. So this is a concept by one of my favorite poet, Rumi. So he mentioned this. I really like it, and I'm very inspired by this. So we receive from God, we give back to humanity. So this is a brief video I shared with you that and this is all my story, why I do what I do. And I hope you will learn some valuable points, some valuable information from it. It will help you, excuse me, to polish your skills. And last, today's life lesson, to have grit, G-R-I-T, grit. All right. So what grit? It means have courage. It shows your strength. And person with true grit has passion, perseverance. So set goals and follow through. Grit is a passion and perseverance for long-term goals. Grit is having a goal you care about. You so much that it organizes and it gives meaning to almost everything you do. So it's very important you have a grit, have courage to get out of your comfort zone, right? So it's very important, and the salient features I will share with you about grit are courage, achievement oriented. You need to follow through the long-term goals with endurance, with resilience, with optimism, with confidence, with creativity, with excellence. And mentally tough leaders are more consistent than their peers. This is how they become leaders. And they have a clear goal in their life. And they work towards achieving their goal each and every day. So that's very important. And according to the leading researcher, I will share Angela Duckworth. She wrote a book as well on grit. And she mentioned that grit can be taught. So how to grow your grit, right? Pursue your interest. Find something that fascinates you. Practice, practice, practice. Get a little bit every day. Connect to higher purposes. Again, as we talk about, find your why, purpose of your life. Ask yourself and how you are helping other people. Cultivate the hope. Give other people hope. Surround yourself with the gritty people, like-minded people. So this is how you will keep your motivation. You will say, okay, I have to achieve my goals. So whatever you decide, and also it's never too late. Whenever you start, whenever you make up your mind, okay, this is my goal, I have to achieve it, just stick to it. And I will always say it's never too late. Of course, you need to be proactive, but if you want to decide it today and keep working on it. And as I shared with you that perseverance is the key to success. Perseverance in any field of your life for your growth. Every day learn something new. Every day groom yourself in all 4 domains. All right. Okay, I think I talk a lot today. All right. So I know a few of you will be overwhelmed, but it's okay. I will keep repeating over and over again. So it will be engraved in your hippocampus. Hippocampus is the part of the brain that keep the memory. So for memory section. Okay. All right. At the end, I would like to thank you, everyone. The best wishes in your careers. And I will be open for any questions for me.
Thank you so much, Dr. Cheema. If anyone has any questions, they can feel free to ask.
Okay, I'm on call as well today, so I will, let's see how many we have.
Sounds great. Thank you. We'll now begin our Q&A session.
Thank you very much for that incredibly informative session, Dr. Cheema. To start off our Q&A, one question we had was, as one of your case studies mentioned, a patient in the emergency department, what is the role of the internist after the patient is admitted to the medical floors?
Right. So this, I want to talk about it. First of all, any acute condition patient go to emergency department. So how it works. So emergency physician who are trained in the emergency medicine, we have doctor, I think in the last week of March, we had emergency physician who did teleshadowing. So patient presented in the emergency department. So the emergency physician evaluate them and they do all the workup, again, same physical history, workup, diagnose, and then they decide patient need to be admitted or in the hospital, or patient can go home and follow with the primary care doctor in the office setting. So this is how the emergency doctor decides. And if patient admitted in the hospital, the reason is patient is severely sick that he need attention to be managed in the hospital for a few days. So then this is the internist part come over there. So internal medicine, or we can hospital medicine physicians. So emergency physicians call internist on call or hospital medicine physician on call to admit that patient. So like if I'm on call, they will call me. I say, okay, they will tell me history, that we did workup, this is going on, patient need to be admitted. I say, okay, what's the diagnosis? We like in the TIA patient, in our first case, patient was back to baseline. Why we need to do admission, right? So these are questions we ask and then say, okay, yes, patient need to be admitted because we did further workup because CT scan didn't show anything, right? It was normal CT scan, workup was normal. So we need to do further workup, what's going on to make sure we are not missing anything. So we do admission. This is the internist role starts over there, hospital care, and we do further workup. I'm giving an example of the same transient ischemic attack patient. We do the MRI, we order the carotid Doppler ultrasound, we order the 2D echo, we do the lipid studies in the morning, fasting levels, we find the cause. So that's our internist rules comes in. And after workout, we see, okay, everything okay, patient is stable, vitals are stable. We do start a telemetry. Telemetry means we monitor the patient on the tele to see any arrhythmias, any underlying cause. We can find any arrhythmias, we can find some source why it happened. So this is all, and then of course we start the management as well. We start treating the patient and we think like patient is stable. Then we let the patient go home. But again, whenever we discharge the patient, placement comes first. Like patients admitted to the hospital, I treat the patient for 2-3 days or 4-5 days. It depends on the severity of the condition. For how long patient stays in the hospital, it depends on the severity and day-to-day basis, clinical improvement or clinical decline. So this is how we, on daily basis, we evaluate the patient on daily basis. So like if I'm on call, I admit the patient, I'm on call for the next 4-5 days. So I will continue following that patient and see the patient, his or her progress, how patient is doing, improving, and then any intervention we need to do, or okay, like in case of a hemorrhagic stroke, we consult the neurologist. Sometimes emergency department call a neurologist right away when patient in the emergency department and then say, okay, admit the patient to the medical floor and they will follow along with the internal medicine team. So there are different scenarios. If a patient, if hospital has a stroke unit, so that hemorrhagic stroke will admit to the stroke unit, then we'll not manage the patient. It will be the neurologist. Sometimes they call us for other, as a medical consultation for other like diabetes management or other cases they need help. So they put a consult. But if patient is admitted to the medical ICU or medical floor, then we consult the neurologist. So this is how it works. I'm just trying to give you a snapshot, like if you are shadowing me in the hospital, and if you ask me this question, so this, you have experienced it yourself. So I'm trying to explain each and every step, how it works. And when patient is stable. So we have a team. It's not only me, it's not only the internist. We have nurses, we have the staff who administer medications, right? They are a very important role. We have social worker on board. Social worker helps us, the placement. Placement means where is patient going to go after the patient get better? Patient going home, patient has a sport at home, patient has a family who can take care if needed, or patient can go to the nursing home, or patient need assisting living facility. So these are all the social worker helps us at that point. And then of course, pharmacy is with us as well. If we start IV antibiotics, we need to switch any resistance patient has, pharmacology, pharmacy is with us. We have social worker, we have our nurses with us, we have house staff. They're keeping the space clean for us, right? So it's a teamwork. So that's I mentioned, together, everyone achieves more. For best possible patient care, it's a teamwork. I hope I answered your question.
Yes, you did. Thank you. So the next question we have is, What is the difference between constitutional and modifiable risk factors?
Right. So constitutional risk factors, I mentioned genetics, gender, and age. So we cannot change it, right? Genetics, we cannot change our genetic makeup, right? Whatever we inherited from our parents, from our grandparents, we have it. And the age, we cannot stop our age. We're aging every day. We are getting older. I would say wiser, right? And of course, gender. So these are factors that we cannot change. And they're modifiable, like patient has a high hypertension. So we can manage her blood, we can control her patient blood pressure with medications, with lifestyle modification, and diabetes. So likewise, we can have a good control of patient diabetes. So these are the risk factors that are modifiable. Likewise, high cholesterol level. So again, high cholesterol level, why we have high cholesterol? So again, diet, right? So that's why I was stressing on physical health. When I talk about diet is very important. Make sure you have a nutritious diet. Don't eat junk food. I tell my kids as well all the time. And they say, oh no, let us do this and that. Kids want to do the way they want to do. But please add nutritious diet. And this is how we can manage our modifiable risk factors. But constitutional factors, we cannot change the constitutional factors. But of course, we can do some preventive measures to reduce the risk factors. Like again, gender, and I mentioned genetics. So we can, if patients have family history of a stroke or family history of coronary artery disease, so we can tell them lifestyle modification, lifestyle medicine will come in, and consult on the diet, exercise, healthy eating habits. It will help them. So this is how differentiate between modifiable risk factors and constitutional risk factors.
Thank you for the answer again. The next question we have is, what are subtypes of clinical research you have been working on in recent years?
Okay, good question. Yeah, so recent years, I'm more on the infectious diseases. Right now, we just submitted one paper on the COVID. It was in myeloma patients, and we just submitted, let's see. And somehow I can tell you the different clinical research and basic science research. So basic science research is all, I'm more in the clinical research, and we do peer reviews. And I recently, of course, I did a long time ago in the neuroendocrine tumors. Neuroendocrine tumors, I can explain briefly, is tumors of neuroendocrine cells mostly in our pancreas, or neuroendocrine cells in our body. So I did on the pancreatic neuroendocrine tumors. I did on incidentalomas. Incidentalomas means that we did workup for some other condition and we find something. Like patient came in with some symptoms of abdominal pain. We did CT and we find some mass in the pancreas. And then we did further workup. We figured out, oh, patient has a pancreatic neuroendocrine tumor. So it's called incidentalomas. So I did my clinical research on neuroendocrine tumors, and they have published as well in different journals. And then currently I'm doing on infectious diseases. And recently I just submitted a paper along with a team, mentors, and for students all together. We did a COVID and myeloma patients.
Thank you. Another question we have comes from Christopher. How would you describe your work-life balance as an internist?
Good question. All right. If you ask my kids, they will tell you more better about it. Okay. So yes, being a mom of 3 kids, as you saw the video of my 5-year-old, of course, she's helping me. She'd say, Mama is studying. Whenever I'm on the computer doing my patient notes, oh, Mama is studying. I'm not studying, I'm doing my patient notes. So anyways, so yeah, it's a challenge. But of course, as I mentioned, there's a time management is very important. Self-management. Remember, that's I'm going to talk about self-management. You have to see what your priorities. So prioritize, of course, family time and professional life. And I call my profession as my 4th child. So I say, okay, so I have to take care of all 4 kids. So 3 kids plus 1 my profession. Of course, a personal life and professional life. And like last night, while I was having dinner with my family, I had a call that I need to address. I was on call for one of my patients, and the patient had a UTI. We were managing as an outpatient, but it got worse. The white count bumped up despite on antibiotics. So I had to address it. Sometimes it happens that we have the family time, but I have to step. My family understands that sometimes when I'm on call, they're very cooperative. So of course, family support is there. My husband, my kids, they're very supportive to me. Whenever I have to step out with some family dinners, they understand. But of course, I try to balance. Again, time management is very important. And So last time is a very pressing issue. I have to address it right away because white count was going up despite on antibiotics. So if it was my family member, I would do the same thing, right? I will step out of family dinner. I will address it right away because I was on call. So that's how, but of course, time management is very important. So you categorize, this is your self time, this is your family time, this is your professional time, and you have to be very well organized, self-discipline. I keep telling my kids, but my kids always say, "Oh, okay." So I keep reminding my kids all the time, self-discipline. Okay, so they tell me, "Okay, we'll do that." But of course, it's again, I was reading about how we develop the habits. So it's all, we are creatures of our habits, like sleeping long hours, sleeping late night, right? What's this? It's all habit, right? Watching TV all the time or spending too much time on social media, keep chatting with the friends. So it's all habits we have. So it's being said, habits make us, habits break us. So it's all habits and time management. So we are creatures of our habits. So please make sure our habits that help us to grow. And of course, when we grow, we can help others, right? Serve the community. I always keep repeating, add values in others' lives. So if we are not able to help ourselves, how we can help others, right? So self-management, self-discipline.
Great, thank you. Another question we have is how many hour shifts did you do during your first year of residency?
Good question. I think at that time there was some rules change in GME but I think it was a 16 hours maximum for us. But for the senior residents, second year and third year, I think it was for 24 hours. But I think they keep changing the rules. I don't know the current rules of GME, but when I was doing it, we had interns were not supposed to stay more than 16 hours. They had to go get some rest and then come back. So when I was intern, my senior residents were saying, okay, you're like, we were on calls sometimes. So not sometimes, every week we were on calls. So interns were supposed to leave after 16 hours whenever they check in. And then senior residents take over. So likewise, when I was senior resident, I make sure my interns has been signed off and has been taken care and take their time off before they start next day shift. But of course, I don't know the current GME guidelines. I'm telling you my experience when I did residency. I hope it will be the same or change. I'm not sure.
Right, thank you. And for our last question from Aisha, give your experience in mentoring. What is the meaning of success to you?
All right, meaning of success. Meaning of success definition is different for everyone. It's a broad terminology. Some people say success is a money, success is a fame, success is having a lot of fortune. The success is to have a lot of followers on the Instagram, on the Facebook, right? So everyone has different definition of success. But for me, I would say success is to know yourself, know your values, find your why. When you know yourself, find your why, and then you have achieved everything, right? What you want to be in your life. We have what is life? Life is a limited time period given to us from birth to death. So this is a certain time period we have, and we are the boss of our body and mind. We have to decide meaning of success for us, purpose of life for us, and how we can help ourselves and help others, serve the community, adding values in their lives. This is, I would say, my goal, and this is I'm aiming for and trying my best. And of course, I believe in one thing: one candle lit another candle. I'm hoping that I'm spending my time this weekend time with you guys with the teleshadowing, and it makes me feel happy and feel good that I can add even one student life value. It will be, we don't need to see, oh, how much kindness we are doing. Just small acts of kindness, keep doing it, and it will be a compound effect at the end. So again, for me, success is to help yourself, help others, serve the community at your level best.
All right, thank you very much. Those are all of our questions for today.
All right, thank you. I'd like to thank you all the TeleShadowing team, all the campus ambassadors, all our TeleShadowing who joined us today and who are online and we have a getting very good response. That's why we keep doing it. And of course, I know it will be overwhelming for a few of them, so please take a deep breath, inhale, exhale, relax, okay? It will be piece of cake for you one day. And as I mentioned, as one candle lit another candle, at one point in time of your life, you will be doing the same thing to others. You will say, okay, now is the time to pay back the community. and it will be a piece of cake for you. So just one step at a time. It will be compound effect at the end. Be persistent, and you will achieve your goals. And I will wish you good luck again. And thank you, everyone.
Thank you very much, Dr. Cheema. We truly appreciate you taking the time to answer our questions, and I would love everyone to please give a warm thank you to Dr. Cheema in the chat box for this incredibly informative session. The thank yous are pouring in now. Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz to this session is now live. We recommend that you finish this as soon as possible, as it's due in 48 hours and there are no extensions after the deadline. You'll need a 70% or higher to pass and receive certification. And as well, I also want to mention, many of our students have expressed interest in pursuing a leadership role in teleshadowing, and we do have positions open on our website, actually. It's teleshadowing.com/leadership, and I'd love for all of you to join our team. Now, on to our future and next session dates. Due to the overwhelming response from students who want to learn more about internal and family medicine, we're going to add more internal medicine and family medicine sessions that will cover most medical conditions to give you the best experience, or kind of this well-rounded experience that you guys will have. We'll also have other specialties as well in between, for sure, as I know that medicine is just very vast and it's very widespread. And these dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And I'm looking forward to seeing you all at our next session next Saturday on May 15th at 10 a.m. Eastern Standard Time with our physician mentor specialized in pediatrics. Thank you so much, everyone, for attending today's session. We hope to see you next week in upcoming sessions. And this concludes this week's shadowing session. Thank you.